Welcome back, everyone, to another episode of Talk Your Abs Off. I'm your host, Abby Clapper, and today I am joined by Dr. Kerry Reller. Hi, Dr. Kerry, how are you?
Hi, very good. Thank you for having me.
Absolutely. Now, I'm very excited about today's episode. I say I'm excited about every episode, but I'm excited about this one. And I will say this one might be a little bit controversial. I know I'm probably going to get some people on both sides for this one, but I just ask that you listen with an open mind and you're allowed to make your decisions at the end and decide what might be best for you or the people that you know. So before we start, Dr. Kerry, could you give a little intro about yourself?
Yes. Okay. So my name is Dr. Kerry Reller. I am a family and obesity medicine doctor in Clearwater and Palm Harbor, Florida. I initially actually wasn't in medicine. I was an engineer, and then I, quit. And I've always been a fitness enthusiast, health enthusiast, and now, when I found obesity medicine, I kind of got to tie the two together. So I'm very appreciative of that. And obviously, the obesity medicine arena has changed rapidly, and even since I became board certified. So I'm excited to talk to you about today, about everything.
I'm so excited too. And I also want to give a little bit of a background as to why I'm bringing this conversation to light. I would say in the fitness industry, from what I've heard and what I've seen, a lot of personal trainers have expressed negative views about obesity medications. So, there's a lot of different terms that are thrown around, and I'm going to ask Dr. Kerry about those. But you might have heard Ozempic, semaglutides, GLP-1s, all of these words that are kind of centered around these obesity medications. And I'm not going to lie, I at one point when I was hearing about all of these things, had also a negative view about obesity medication. I thought that people were maybe trying to take a quote unquote easier way out. But I also am not afraid to admit when I'm wrong. So, as a personal trainer, I'm certified through the American College of Sports Medicine as an exercise physiologist. I'm required to do 60 hours of continuing education credits every 2 years. And one of the continuing education credits that I recently did, I think last year I took it, was about obesity medication. And honestly, it changed my view of obesity medications and who should use it, who shouldn't use it, things like that, which is why I think it's important to talk about it, because there are definitely people who can benefit from it. And then, but it's also not for everyone. So that's kind of where this conversation is coming from. I think that, the people who are using it, the proper people who are using it, need support from the fitness people in the fitness industry around them to make sure that they're doing it in a healthy way. And what better person to talk about this with than Dr. Kerry, who is a doctor who is helping others use this obesity medication in a way that works well for them. So that's a little bit of background as to why this conversation is coming to light today, especially because it's such a trending topic. So, Dr. Kerry, as we get started, I threw around those words: Ozempic, semaglutide, GLP-1s, there's Wegovy, there's all these other terms. But can you just clarify kind of what those terms mean, which ones are being used, which ones aren't?
Sure. So let me back up to say that, one, I love that you did continuing education, because I did a presentation on obesity medicine to athletic trainers, and I hope they got as much from my presentation as you did from yours. And then I'd also like to say that obesity medications are not new. So phentermine is something that is cheap and affordable and has been around for a very long time. There's Contrave, there's Qsymia, all these medications have existed for a lot longer than all these new ones that, bring up. And they're not even that new. So these GLP ones that you're mostly referring to, and then there's a combination GLP and GIP medication are, well, the GIP combo is a little bit newer, but the GLP-1s have been around for at least 10, 11 years and used to treat diabetes. So GLP-1s are injectables. They inject once a week for some of them. The old one, Saxenda, was once a day. And they have obviously gained a lot of popularity because the newer ones like Ozempic and Wegovy, which are both called the generic word semaglutide, and they're all the same drug. Okay, so semaglutide, Ozempic, Wegovy, all the same. The difference is that Ozempic is FDA approved for diabetes and actually cardiovascular disease and now chronic kidney disease reduction. And Wegovy is only approved for obesity. And it's also can be approved if you have a cardiovascular like a heart attack or stroke history as well. So these are all the same drug. And the GLP-1s work by delaying the gastric emptying of the stomach. And they also increase satiety because they act on the brain and, make you feel like you're fuller. It's a something that is new, I think, is more of the brain reactivity than the stomach as much. But so they're exciting because they work so much stronger and better, and you can have more weight loss than you would with the other medications that I mentioned. Those might give you like maybe 6% weight loss. These newer medicines are pushing to like 20% weight loss, which is a big, big deal, because even when we think about bariatric surgery, that is also around the similar, it's reaching the same amount almost as bariatric surgery. Is pretty exciting. So, like I said, these are actually not that new, and they're just having great efficacy in treating that. And what's exciting is that in the obesity medicine world, we believe that obesity is a chronic disease, and there's comorbidities associated with them, which means like cholesterol, blood pressure issues, obviously diabetes or insulin resistance issues, even like cardiovascular disease, heart attacks, and strokes. And all of these are shown to be improved and related to, they're shown to be related to weight. And when you reduce the weight, we're seeing improvement in most of these things as well. So they're not new is the biggest thing on that. And I think that's a misconception a little bit. So.
Absolutely. I think a lot of that comes from like social media, right? So even 10 years ago, we weren't using social media to share the things that we're using now. Everything is so readily available, which is great, but it's also, we get a lot of information all at one time. And thank you so much for kind of defining what each of those are and, the differences between them. Because I think a lot of times, we just don't know what all of these different words are. And one of the other things when I was listening to this continuing education credit was, so it was kind of defined. So obviously it's should mostly be used for people who are obese. So I think what that doctor was talking about was it was people with BMIs, and BMI, we can go into a whole conversation about that at another time. But BMI is if you have a BMI of over 26 plus like a comorbidity, that they could use the obesity drug, or without the comorbidities, you could just have a BMI of 30. Is that something that sounds about right?
It's 27, and it's
Okay.
not all insurances. So we had a recent denial that someone's BMI was 29.8 or something like that. And that insurance company didn't care if you had a comorbidity or not. If you didn't have a BMI of 30, then you couldn't get approval. So I should also mention, because I didn't do it earlier, but Mounjaro, Zepbound, and tirzepatide are all the same thing. Mounjaro is an FDA-approved drug for diabetes. Zepbound is the one that's FDA approved for obesity, and actually also with obstructive sleep apnea. And then tirzepatide is just the generic word for all of those. And those are GLP, GIP medications. So GIP is another hormone in the gut, and it acts on that. And it has more weight loss and success than even the GLP ones. And they recently had a head-to-head trial where Zepbound beat Wegovy.
Oh, wow. That's interesting. Huh. Well, that's good. I think that there is a lot of research that's going on right now with them, with all of those medications, which I think is fantastic. And, we're going to talk about this whole, everything that I learned. I re-listened to it again so that I made sure that it was all top of mind before I came on here, because I really do think that it's really important. And so many people ask about it. So you kind of explained how the semaglutides work, how it's more essentially like an appetite suppressant, would you say?
I mean, yes, the way that it works on in the brain, yes, it's hitting those satiety centers in the hypothalamus, and that's really kind of shutting down that hunger, as it makes it more manageable, let's say, and also really helps to suppress cravings and things like that. And that's just like a game changer for a lot of people. Not thinking about food all the time, not just not being as hungry, but the cravings are, way down, and it helps it be more manageable, for sure.
Yeah, I've heard it labeled as food noise, which was a new term
Yes.
that I'd heard of. So that food noise is when, let's say you're done eating a meal and you're still thinking about food. Or, you can't, let's say you have like a carton of ice cream in the freezer, and you can't stop thinking about it unless you eat the whole entire thing. So what I've heard from some people is, that food noise reduction has been super helpful. And I think when we're talking about obesity, obviously more movement, less sedentary lifestyle, and eating well also go hand in hand. However, when people are when someone's trying to manage obesity, which I believe is it a chronic is it considered a chronic or a, what
It
word am I
depends
looking
who you ask. So yes, the Obesity Medicine Association, the World Health Organization, and gosh, there's another like a special like academy thing that believes that obesity is a chronic disease, right? It's a
for?
relapsing, it goes in remission, it comes back. It's we believe that it's a chronic disease and it has associated inflammatory markers and things like that are associated with it. So not all entities believe that, or it's still that we're working on that, I guess. But it has definitely been labeled as such, and the obesity medicine community believes that it's a chronic disease.
Okay, that makes sense. So, I mean, if we're looking at it as a chronic disease, when we're looking at other chronic illnesses, there's different plans that work for different people. Not everything works the same for everyone. So, if you as a personal trainer, and for the, I'm hoping other personal trainers are listening to this and we can kind of have an open discussion about it. But if we're personal trainers, we were taught, more movement, less calories is, not a significant amount of less calories, but you want to make sure you're in a caloric deficit. Now, for someone with obesity who has that food noise in the background, eating less isn't necessarily going to fix everything, because that food noise that's happening, they're not going to be able to eat less, right? You can move as much as you want, but by having like this extra little helpful tool to reduce that food noise, to change those satiety hunger cues, can be really beneficial in kind of kickstarting, to start seeing results. You want to start getting those small wins so that you can, have a benefit, and want to continue with it. So it's not to say that, someone who is taking semaglutides that, you shouldn't be exercising and shouldn't still be continuing to eat right. I think that's one of the biggest things as a personal trainer that I think about is, if someone is taking an obesity drug, but not moving and not changing the way that they're eating, it's going to be really hard for that to be a long-term sustainable change. I don't know. What do you think about that?
I totally agree. It is a lifestyle supported thing. You have to talk about behavior. You have to talk about movement. You have to talk about nutrition. We can't just give the medicine. The medicine is just a tool
Mm-hmm.
in, the hat of tools that you can help have a little bit, more help and support on your journey to become healthier overall.
Yeah. Now,
Yeah.
is it meant to be a lifelong tool, or is it possible for someone to do it short term?
So everybody loves that question, but I believe in both. Now, the Obesity Medicine Association will probably say that if you think about it, if it's a chronic disease, it needs to be treated as such, right? But it doesn't mean we have to continue all the tools the whole time, right? You can have a balance between the tools. So maybe you don't need it all the time, but maybe, you need it, I don't know, once a month. Let's just, for an example, it's really supposed to be every week, right? And it's written that you will have weight regain if you come off of the medication, and that's certainly possible. But maybe everybody is different, and they may be able to do it a little bit longer, like 10 days or something, rather than every week. So, I mean, there's an Obesity Medicine Association answer where it's a chronic disease, and you're not going to take someone's blood pressure medication away, or you're not going to take their diabetes medication away or their cholesterol medication away, where I may not agree with all that, because if we lose weight, we can get off all those.
Right.
But, but if you treat it as a chronic disease, you're probably going to want to use it chronically. But I do think everybody is different, and this is individualized medicine. And there's certainly people that could use it for, like you mentioned, like maybe they can be using it for a short while to get that motivation to get going, to be, healthier in general. And then once they're feeling that, maybe they can wean off of it. I don't know. It's a possibility, but everybody is going to be different. And something that you mentioned earlier, I wanted to point out, was that when people are losing weight, their hunger goes way up, right? That's ghrelin hormone is just, hard to deal with, right? And that's where this medication helps, come in, right? It's suppressing the hunger hormone so that you're not constantly either thinking about food or seeking food, because we do believe in this kind of theory of set point where your body is always wanting to go back to the highest weight that it was. And you have to perhaps create a new set point if possible, or just always be somehow needing support to suppress those hunger hormones, because your body wants to bump you back up where you were.
Yeah, I think that makes a lot of sense. And they actually talked about, honestly, what you're saying is pretty much what this other woman was saying in the continuing education that I listened to. So I love that there's like an alignment there. Um, And I think that the set point is really interesting. I used to be a health coach for a weight loss company, and we would talk about set points as well. And you need to make changes to your lifestyle or to whatever routine you're doing when you hit those set points occasionally, just to, start to like create that new set point. And I also think when we're talking about like chronic conditions or chronic illnesses, usually people have like a medical support team, right? Let's say medical. There's a support team. So hopefully there's more support. So you have your doctor. Maybe there's someone advocating for you. Maybe there's a therapist to help you with some of the stuff in the background. But when we're looking at like obesity management, I think, and you can interject if if I'm saying anything incorrectly, but having like a dietitian that you're working with as well can be helpful to get you on like a good plan. Psychologist potentially, or therapist to help you maybe work through some of the ways that you think about food, or the ways that you've grown up with food. Things like that can change. Having a coach or a trainer helping you with movement, helping you find an accessible way for you to get movement in a safe way so that you're not overdoing it, or doing something that's good for you. And also, still working with your doctor as well. So I think having a good support team around you, along with, support from your family and friends, makes a big difference too.
Yeah, I mean, I would say if you found all of those kind of things in one package, you've hit the jackpot. But
Right.
I would say, so dietitians are not always covered by insurance, but it's certainly that's helpful. We also recommend health coaches, and if you were one, kind of what they do, and they can help with like similar things to dietitians and nutritionists, I think. And then behavioral thing is a big part too. So if there is, depression, anxiety, even binge eating disorder or other eating disorder things, having a, mental health counselor or therapist is also really helpful. And obviously if you're needing medication, having a doctor on board is, a need as well. And you mentioned one other, fitness, obviously. So that would really be like an extra, and not all insurances cover that. So that's unfortunate, but there are, ways around it. But I think that would kind of give you like a full package thing, which is, it's hard to be healthy in our society. So if you've got all
Yeah.
these people supporting you, then that's fantastic. Yeah.
Absolutely. But it is definitely challenging. I will absolutely agree to you on that. So if someone is on these obesity medications, let's say maybe if they decide to choose it for the long term, does it affect someone's metabolism?
Yeah. So I think that is in the hands of the individual. So is it going to affect the metabolism? Yes. So if you looked at the Biggest Loser study, I mean, that's without medication, but these people were doing intense exercise, right? And they were cutting calories and eating very low calories, right? So they lost weight, of course, but those that had success, and then some that didn't, regained the weight. But what we saw when they regained the weight, so as you lose weight, your basal metabolic rate goes down, right? So you have this new basal metabolic rate. When they regained the weight, their basal metabolic rate did not recover. So it's really any weight loss, not necessarily with the medications, that would make it any different. So if you're someone that has yo-yoed big weights throughout your life, it will be very hard, and you could have a very suppressed metabolic rate. We have a machine in our office that does, the resting metabolic rate test that, measures the carbon dioxide expiration or exhalation. And it's amazing. Like sometimes I always expect it to be low, but like one patient, it was like super fast. I was like in shock. I'm like, okay, maybe she doesn't yo-yo that much or anything like that. And then another person was very low. And, ways to, I guess, improve that is, kind of things that you're probably focusing on, right? But typically any weight loss, it's not the medication that is necessarily messing with the metabolism, right? I mean, if you're eating nothing, I think that is going to mess with your metabolism, right? But it doesn't have to be from a medicine. So it's more the weight loss and maybe the lack of eating. And some people would argue, the muscle mass situation as well. But that's because they're not using it as just a tool. They're trying to use it as the go all, like an end all, and that it should not be used in that way.
Right.
Yeah.
Okay. That makes sense. Yeah, I think that makes a lot of sense. So kind of going along those lines, do you see if there are any like long-term risks or safety concerns when it comes to using the obesity medications?
So, like I said, they're not new. So, the long-term effects of at least Saxenda or semaglutide and liraglutide have been, shown to be safe. Obviously, anyone who has a family history of multiple endocrine neoplasia or medullary thyroid cancer are not candidates. However, those studies were only done in rats in the first place, so we don't really think that is, that important. But it is part of the label. So you have to make sure that the person, doesn't have those things. And then somewhat increased risk of pancreatitis. Obviously, there is, short-term side effects as well. Like GI symptoms, usually like nausea, vomiting, diarrhea, constipation. Those are the most common ones. Some people have increased reflux. There's some people depression is cured. Some people have a little bit increased depression. So there's a lot of arguments whether because it's kind of taking away pleasure from eating food as much. And if they're not finding pleasure elsewhere, then that could be, something that we think maybe that's why it's related to increased depression. But the long-term studies, show that they are safe. I think like I said, if you're not doing these big weight ups and downs, then I think it's going to be more safe for, metabolism and things like that. There is a rare eye thing that has been associated, but it is like less, it's barely more than the general population. I'm forgetting the actual name of it, but it's so rare that it's, people are concerned about it, but it is not seen to have a more risk than the general population.
I mean, obviously, because I think I'm in the fitness industry, I would hear like the worst of the worst, like, the
Yeah.
1% stuff that, that was causing people to have the most issues with it. But, because like, from what I heard in my continuing education was, everyone who goes in for this medication should be being evaluated by the medical professional. And so obviously if someone does have, like you said, the history of, or family history of those things, that they wouldn't be good candidates for the injections or however they're going to take the medication. So there was that. And then the other thing, because obviously I'm not privy to this research information because I'm not doing the research on it, but what her and her team were looking into, because they were talking about the lean mass and how it affects the lean mass. So no matter what you did, or no matter what the different groups did, it was the people on the injections, and then it was the people on the injections who were eating in a caloric deficit, and then it was the people with the injections who were working out. Lean mass all decreased pretty much the same amount. Now, for those in my audience, when we're talking about lean mass, it's not just muscle, right? So it's muscle, it's internal organs, it's tissues. So lean mass doesn't directly equate to like muscle mass. So when we're talking about weight loss, when someone is losing a lot of weight, a lot of times you're going to lose muscle along with losing fat. Like that's just a part of it. However, when you are strength training during like weight loss, however you're doing it, you can still maintain a lot of that muscle mass, different than lean mass, your muscle mass. So the muscles, your muscular function, things like that. So that's where I think like it is so important, where if someone is choosing to take these obesity medications, that they're continuing to exercise, and specifically like strength training. Do you think that that's reasonable? Do you think that more cardio needs to be involved, or is it kind of all still up in the air?
Well, I do think cardio should be involved mostly for cardiovascular health, but the strength training is the key component, I think, and obviously protein consumption with having any really weight management or weight loss plan. It doesn't, including medicine or not.
Mm-hmm.
So yes, like you said, you're going to have lean mass loss, and we try to keep it less than 10% if possible. But some people don't. Like, it's amazing if they're doing weight training and do fantastic on that. Obviously, I think slower the better.
Mm-hmm.
Then there isn't very much lean mass loss, and it's something we track in our office pretty closely. We have the body mass index, which is the weight over the height squared, and then we look at the skeletal muscle index, which is the skeletal muscle mass. I wasn't sure. I couldn't remember if it was exactly the lean mass, but skeletal muscle mass over the height squared. And then I'm tracking that. So, and then obviously a percent body fat as well. So, we definitely see people who are on the medicine who are actually doing, the physical activity that don't lose, muscle mass, or at least it's keeping even. So, I think the biggest thing is including resistance training
Mm-hmm.
and eating adequate protein as well.
Yeah.
And then it's very possible to have success without losing lean mass.
Yeah, I love that you're using like body fat percentage and scale that you're tracking skeletal muscle on top of BMI. I think that that's really
Mhm.
important because I know some people will look at BMI and it can be skewed based on how much muscle somebody has and all the different things. So
Mhm.
I think having that full picture of the person is really super beneficial. So I'm going to back up a little bit because when we were talking about Wegovy, you said that one was approved for, I think you said type 2 diabetes.
Wegovy is for obesity.
Sorry, Ozempic
Ozempic is for type 2 diabetes.
for
Yeah.
type 2 diabetes. So um, when this all first came to light, I don't want to say it came out because I didn't even know it came out that long ago, but when it started to become popular, people were saying, "Oh, this is a medication for people with diabetes. We're taking it away from the people who need it." Debunk that for me.
Yeah. So I think it was 21 or 22, I want to say even 21, that, you know, Ozempic was out, and I don't know if Wegovy came out but a year later, but um, people did have that thought that they are, taking the medication away for, the patients who are diabetic and who need it. Now, I guess I have mixed feelings about that because, I mean, if you're treating a patient with a certain amount of obesity and there's obviously insulin resistance going on, and insulin resistance is a spectrum. So diabetes is, when your A1C or the hemoglobin A1C is greater than or 6.5 or greater. And then there's prediabetes, which, is often not diagnosed enough, but most of the adult population has it, is 5.7 to 6.4. And then there's this whole idea that there's insulin resistance that is occurring 10 years prior to having a diagnosis of prediabetes, which half the doctors miss in the first place. So I would argue that a patient who has obesity is probably already have some level of insulin resistance and also, totally is in need of the medication or something to help them, whether it's just lifestyle intervention at that point. But they're on that path too. So why not use a medication sooner to help prevent that from continuing to progress? Now, there have been diabetic medications for a long period of time, and yes, these medications are better, but I think it was just hard during that period because there was such a shortage, right? And because of that shortage, it exploded an entire industry of the compounding medication and people getting these medications, I would probably argue, in a non-safe way.
Mhm.
So whether it's taking away from the patients who have diabetes, I mean, it's hard to say because perhaps that patient's going to be in their shoes in a couple years, right?
Mhm.
Well, how are you to say who deserves and doesn't deserve the medication? Now the FDA and the drug companies and the insurance companies are going to tell us that, right? But when this whole compounding world opened, they kind of went around that need that I guess the insurance companies and the FDA to say, okay, well, I want that medicine to help me. I don't know. It depends on the patient of whatever they're deciding. But I don't know if I'm going off on a tangent, but it's just hard to argue whether they are taking that drug away from the patients who need it because it sounds like everybody could have needed it, and it's
Mm.
just a different spectrum.
Yeah. Does it affect type 1 diabetics as well?
So, no. So, type 1 diabetes, unfortunately, because they have no ability to produce insulin on their own, they have to use insulin. But insulin is a fat storage hormone, right? And it does other things too. But because of that, a lot of type 1 diabetics do end up having excess weight. So, therefore, some type 1 diabetics, under their endocrinologist, are also on some of these drugs to help have better glucose control, including their insulin. So they have to have insulin, but then they're also on these to help. It's ironic because this drug also increases the release of insulin from the pancreas. But anyway, it seems to help work because it's having the satiety effect and the cravings effect. So they're getting improved glucose control from that respect, right? So insulin is released when we eat something, right? Other things other than fat. So um, if you're eating less, then your insulin is not going to be released as much anyway, right? So
Mhm.
it's helping in a different roundabout way. So while it's not for type 1, I won't say that people are not using it for type 1.
Okay, that makes
Yeah.
sense. That is so interesting. Yeah, and I think that's something that a lot of A lot of us, myself included, didn't really understand. We just see the headlines that are like, oh, they're taking away medication
Mm-hmm.
from people with diabetes, and then it sends it
Yeah.
into a whole thing. So thank you for clarifying that. That's really helpful. And then also shifting the topic just a bit, something else that I've heard that I haven't looked into as much, but maybe you can shed some light on it if you've heard anything. Can this medication be helpful for women who have PCOS, which is polycystic ovarian syndrome?
Right. So it's not really shifting the conversation much because I was just talking about insulin resistance, right? So PCOS is, kind of a misnomer. We more want to call it like a metabolic problem. And metabolic problem in this case is also usually insulin resistance. Now, there are patients who are normal weight and have PCOS, and they're not necessarily falling in that category, but it could be a different modality of how they get that. But with PCOS, it's considered to be insulin resistance. Usually there is an elevated insulin. So yes, I don't think it's not approved or anything like that for PCOS, but I definitely think that it could be, right? So it's another medication that is used for diabetes called metformin is often prescribed for PCOS. So metformin works differently. So I mentioned insulin resistance, right? So metformin makes your cells more sensitive to insulin, so they'll listen better. So they'll bring that sugar into the cell. So there's less likely to have, elevated sugar later on as well. So we give metformin for PCOS, and we also, I'm assuming, I think these medications will definitely be approved for it eventually. There's not much is not going to be approved for that's related to metabolic health, in my opinion, like for, not to change the subject completely, but metabolic steatohepatitis, which is otherwise known as non-alcoholic fatty liver disease, or MASH. I mean, the trials are for that. They're, researching that as well because it's also a metabolic health, metabolic problem. But so PCOS, it can help, regulate menstrual cycles, but so can lifestyle and, improvements as well. And so can metformin, because metformin is also working directly on that insulin resistance on hand. And the same thing that I was saying that the semaglutide and tirzepatide do, where they are overall decreasing the insulin, even though ironically and counterintuitively, they increase the insulin release from the pancreas. So, but because it's overall, you're not eating as much, it's reducing the insulin, right? Even though because the sugar, the way that it controls the sugar, it's increasing the release of insulin from the pancreas. It's very counterintuitive until you think about it. The overall consumption of the food is down because of the other effects that the drugs have, such as the satiety, the slowing of the gastric emptying, and everything like that.
Yeah. Wow. That's fascinating. I guess I didn't realize that PCOS was more of a metabolic condition. That makes actually total sense. Is there anything that you think most people, like, most frequently asked questions?
I mean, there's the whole compounding situation that's going on right now, where all these people who had access to the medication through this rule where it was the medication was in shortage, like you were saying with the diabetes, right? Because other people were finding out they wanted to use the medication, right? So they were they were taking it off label, right? They didn't have diabetes and they were getting it at first, and then the Wegovy came out and they were getting that, but not everybody could get it because it's not on anybody's insurance plan, right? So with the compounding medicines, all these patients have been taking these medications for a long period of time. Now, what I have great concern about is that they weren't doing it properly. They may have had additives or preservatives or other vitamins added to it in an unsafe way. They weren't getting it from an FDA approved or regulated 503B facility, which is, more enhanced safety measures. And now all of a sudden those facilities cannot make the medicine anymore. So my concern is that what is going to happen, like we talked about how it doesn't mess the metabolism, right? But weight loss can. And now they don't have access to these tools that were helping them, right? So what's going to happen if they, are they going to regain the weight? They don't have that tool. They didn't go to their team, right, of their behavior therapist, their doctor, their fitness expert, their dietitian to really put in those lifestyle work. What's going to happen? I don't know. That's where it's very concerning of where the future is right now. Like last week, I mean, this is May 28th when we're recording. It was a week ago. They were no longer allowed to dispense and distribute the compounded medication, semaglutide, and tirzepatide was a couple of months ago.
Wow.
Yeah.
Yeah, that's concerning. And I think there was, I don't know, did you watch the Super Bowl this past February? Maybe a little bit. Okay. So I remember one commercial specifically, and I only remember it because it took me on a roller coaster of emotions. It was for, what was the company? I think it's like Him and Hers or something.
Oh, yeah, yeah, yeah. They had a big
I'm
ad.
sure
Yeah.
you saw this commercial. So if for those who saw it, here's a reminder. For those who didn't see it, this is what happened. So they started the commercial, and it was these people living healthy lifestyles. They were eating well, they were exercising, and this commercial was talking about healthy weight loss. And then all of a sudden, they hit you at the end with, and here's the semaglutide that is going to help you like do all of this stuff. And my friends and I all just like sat like jaws on the floor, like, we were doing so good, like before we hit, like before you like sideswiped us at the end and like showed us this. But would that be a good example of a company that like people are getting it easily that might not necessarily be able to get it in the future?
Yes. There's a lot of online companies that
Mm-hmm.
are easily getting it. Some don't even like, require like any history. And what's really sad is they didn't document what the, previous BMI was. They didn't get any metabolic labs. So you're not seeing if
Mm-hmm.
anything was better. You're not even diagnosing if they had diabetes or not when they could have got an FDA approved medication. Right.
Right.
So, I mean, there's a lot of things that weren't done the right way, which I think is affecting everybody, right? And now, like, as a patient walks in my door, I'm going to have to like get a great history and believe them. Oh, your BMI was this, like how do
Mm-hmm.
we prove it? And I
Mm-hmm.
mean, I will say that they were the problem was is they were super expensive, right? They
Mm-hmm.
brought the price down, but not nearly enough. Other countries, it's way more affordable. The fancy pens that they come in is part of the problem. Like they're all
Mm-hmm.
patented. The drug is patented, which is the whole issue, right? That they
Okay.
can't make the compounded. And then the pens are, a different, they're great, but like they make it harder to create the, mass distribution. So they're now offering it in vials if you pay
Okay.
cash too. So they're
Interesting.
trying, but
Yeah. So I guess to kind of round out this conversation, the way that I feel about it is that, and everyone is welcome to disagree and make your own, thoughts about it. But unless someone is obese and truly needs a tool that's going to help them to see success, I don't believe that it is made for everyone, that everyone should be able to access it, kind of like you said, unless you're talking to a medical professional. I think it's far too easily accessible. If someone is going to use it, I think working with a medical professional is going to be the better option, especially because it's also going to encourage, as a medical professional, like as yourself, you're going to encourage people to eat healthier and also change their lifestyle. Whereas if you're ordering it online, you don't have to be accountable to anyone for, your actions. So I don't know. Those are just my personal thoughts. I do think that it can be beneficial for the right person, and that it's also not for everyone. What is your overall opinion on it?
yeah, well, I think working with like a medical professional is very important because there could be other underlying reasons, right? Hypothyroid, like doing some labs, ruling things out, medication side effects can cause weight gain. Like there's other things that could be going on that leads to the weight gain, and not to throw in like perimenopause and things like that, but that is also something that could be better controlled to help improve things before jumping to these medicines if you need to. Now, there is a whole like microdosing community. I have no idea how they're going to do that with no more compounding medication. But I think there is some thoughts that it can help with like decreasing inflammation. But then again, if you're losing fat is inflammatory and you're going to be
Mhm.
decreasing inflammation in that way too. So it's hard to say it's due to the drug. But I think with the FDA approved drugs and these more strong things, I think they are definitely, more appropriate for patients who are having that elevated BMI and the BMI with comorbidities. And there's new drugs down the line, and some of them are even too effective, like the retrutide or however you say it. It is having so much good success that I think it's a concern that really it has to be like BMI of 40 or something for it to
Oh
be,
wow.
useful for. We don't know yet, but
Yeah.
it's just, seeing some results preliminary from those trials is just crazy. Like it's too fast and it's just a
Mhm.
lot of weight loss that, it really does need to be reserved for the community that is those really high BMIs and things like that. But I mean, I think everybody is just so medicine is definitely moving toward personalized medicine, right?
Mhm.
And it really needs to be individualized in those decisions. And that's more of what I believe. And because you also have to think about where people come from. Like, I can't just look at you and see your BMI is normal. Who knows what it was, several
Mhm.
years ago? Who knows how hard you're working, right? And could it be helpful to, have a little support, right? I don't
Yeah.
know.
Mhm.
It's I don't know. But I definitely think it's an individualized approach. And I definitely push toward, if there's a shortage or anything, you need it for the people who are most vulnerable in that population. Yeah.
Yeah, I think the individual approach is great because I think the medical field has it's come a long way, but it still has a long way to go, and that's why I love getting to talk to you because I feel like you're definitely more open minded and progressive about it instead of putting everyone on like a cookie cutter. This is the
Mhm.
medication that this person needs. This is the medication that everyone who has this condition needs. So, anyways, I think that it's definitely better for people to have a little bit more of an open mind. Talk to your provider if your provider if you don't feel like you're being heard, if you feel like you need extra support, there's nothing wrong with, talking, getting a second opinion and kind of, doing it that way and finding what's going to work best for you with your medical provider, obviously.
Mhm.
But my last thing that I have, the last part of my show, it's called absolution. Within the fitness industry, sometimes things can be kind of toxic. And so this is a fun way to try and get rid of some of that toxicity. So basically, I want you to tell me what is one thing that you think that should be absolved of in the fitness industry and that we should free ourselves of the guilt and punishment of.
Well, I have to keep it on theme, right? That the medication is not cheating.
Right.
It's a tool, right?
Mhm.
So I guess absolve the shame around needing medical support to help you in your health and weight loss journey. It's the same thing. Like I was saying, if ever blood pressure, mental health, weight, whatever it is, needing a medication is not failure.
Mhm.
But working with, your doctor or whatever, and trying to figure out, is it, ruling out things and, doing labs and really getting a good history, I think is very important. So I think it's not cheating. It is a tool, but you have to do the rest of the stuff too, or you won't have as good success, and you never know what's going to happen in your future if you don't do all the things the best you can. Yeah.
Yeah, absolutely. Still got to put in that hard work.
Yeah.
Awesome. Well, thank you so much, Dr. Kerry. This was so insightful. I learned a lot. I know my audience is going to absolutely love this. Love it or hate it. I don't know. They're going to do one of the two, but they're going to listen to it and they're going to learn something. So I thank you so much for your time today and for your expertise in this area. I think it's something that a lot of us are just very curious about. And so it's nice to have maybe just a little bit more information about it. So thank you for your time today. Very much appreciate it.
Yeah.
And
Thank you so much for having me.
absolutely. If anyone wants to follow you, you also have your own podcast. If you want to share a little bit about that and then also tell us where they can find you.
Yeah. All right. So I have Get Healthy Tampa Bay podcast, where I bring experts like yourself, anybody in the health and wellness space, to do the same thing, teach. We have a lot of doctors and different medical topics too, but anything in the health and wellness space. And then my practice is in Clearwater and Palm Harbor, Florida, at Clearwater Family Medicine and Allergy. And on Instagram, I'm on Kerry Reller, MD, and Clearwater Family Medicine, and it's kind of the same stuff on all the other things like Facebook. What's the other one? LinkedIn. Yeah, all the spaces, like you said. Yeah.
So give Dr. Kerry a follow. I follow her. I love seeing her stuff. She's got some great podcast episodes that are very informative. So definitely check those out. And otherwise, that's it from me. And we will see you on the next episode of Talk Your Abs Off.